So we're going to talk very briefly about Crohn's disease, which is primarily an inflammatory bowel disease. However, there can be inflammation anywhere along the gastrointestinal tract from the esophagus to the anus. Now, with Crohn's disease, in terms of, if you were to look at, sort of tissue under the microscope, what you would see are these things called skip lesions. So you might have an area of inflamed tissue followed by an area of healthy or normal tissue followed by another area of inflamed tissue. And that's what's known as a skip lesion. Very often Crohn's disease is kind of spoken about together with another sort of inflammatory condition called ulcerative colitis. But ulcerative colitis is specifically referring to inflammation of the colon, whereas with Crohn's disease, the inflammation can be anywhere along the gastrointestinal tract. Now, in some cases, systemic manifestation and other tissues are also affected. In terms of causes, there is sort of a genetic predisposition, and that's at the level of the HLA or the human leukocyte antigen, combined with exposure to food allergens or some microbes or even something else. Because remember, the causes or the triggers of a lot of these autoimmune conditions are still unknown. I have a sister with fairly debilitating Crohn's disease at different times, and she's absolutely convinced that her trigger for Crohn's disease was after she got salmonella food poisoning from chicken. And another bacteria that is implicated is Mycobacterium. Now, as I mentioned, it is a very variable disease from person to person. Some people might just have, mild sort of episodes of inflammation, whereas for others, it's extremely debilitating and causing symptoms like intermittent diarrhea, abdominal pain, signs like weight loss, fluid and electrolyte balances, and also just that general feeling of, not being right, and a low-grade fever. For those people that have very severe Crohn's disease, very often the inflamed tissue needs to be resected, and resected is just a word to describe how something is, surgically cut out. So that's all we're going to say about Crohn's disease. The next autoimmune disease is myasthenia gravis, and myasthenia gravis is a very specific autoimmune disease where an antibody is being produced that specifically attacks acetylcholine receptors. Now remember, these acetylcholine receptors are found in the synapse where, the somatic motor neuron is innervating a skeletal muscle cell. And we know that this is called the motor end plate. So these antibodies are against acetylcholine receptors. By binding to the acetylcholine receptors, they either block acetylcholine binding, so they antagonize acetylcholine, or they bind to the receptor to cause internalization and destruction of the receptors. Either way, all of this is going to cause, decreased synaptic transmission. This is a progressive disease and leads to progressive muscular weakness and fatigue. It's also got an insidious presentation where it's not sort of diagnosed for about 1 to 2 years. And very often it's diagnosed based on the signs of sort of, muscle weakness in the eye, causing this droopy eye, or maybe somebody has issues with swallowing, or just slurred speech can be the sort of the first symptoms. And this is what we're looking at here. If we zoom in on this axon terminus of this axon of the neuromuscular junction and look at it over here, you can see that we have this synaptic cleft here. We have our presynaptic terminal. We have these synaptic vesicles containing acetylcholine that needs to be released into the synaptic cleft and diffuse across that short distance to then bind to a gated sodium channel. And when acetylcholine does bind to that, then sodium will rush into this post-synaptic cell, and that will cause depolarization of the sarcolemma of that skeletal muscle cell. You're looking at here, I zoomed up even further, we have our action potential traveling down to the presynaptic terminal, opening these voltage gated calcium channels. Calcium rushes in, and that causes these vesicles containing acetylcholine then to fuse with the membrane and to be released into the synaptic cleft. That acetylcholine then diffuses across the synaptic cleft and binds to its binding site on one of these ligand-gated sodium channels, and that binding will open the channel, and then the sodium and positive charge will rush into the postsynaptic cell, being the skeletal muscle cell, causing the sarcolemma of the skeletal muscle cell to be depolarized, and that action potential then is propagated in both directions. And ultimately that's going to lead to muscle contraction. So what you have to imagine here is in this extracellular fluid, there are sort of auto antibodies sort of floating around in this synaptic cleft. And they compete with acetylcholine for binding to the acetylcholine receptor on that ligand-gated sodium channel. So they antagonize acetylcholine. The other thing they can do is bind to the receptor and cause the internalization and destruction of that receptor. So therefore it's harder for, acetylcholine to find a receptor to bind to. So over time, if a skeletal muscle is not being innervated by a neuron, it's going to start to atrophy. So it's going to start to waste away, and the proteins that are used for contraction are going to be broken down. And so the skeletal muscle then will lose mass and it will lose strength, and so it won't be able to contract as well. And that's what we're seeing here with myasthenia gravis, which again is a very variable autoimmune disease. In some people, it might just be limited to the droopy eye or the slurred speech, but with other people, it might affect the muscles of breathing. So let's just summarize myasthenia gravis. It is a rare autoimmune disease where autoantibodies bind to acetylcholine receptors in the motor end plate. They either antagonize acetylcholine binding or cause receptor internalization and destruction. That then will lead to decreased synaptic transmission. It is a progressive disorder and it leads to skeletal muscle atrophy. And that's because of the decreased synaptic transmission and that breakdown of those, actin and myosin contractile proteins. The symptoms initially are eye muscle weakness, problems swallowing or dysphagia, and slurred speech, and in more severe cases, respiratory muscles are affected. Some of you may be interested in the treatment for myasthenia gravis, and if you were paying attention right back in the first lecture, I did talk about a drug called neostigmine. And neostigmine is an acetylcholine esterase inhibitor. Now, acetylcholine esterase is an enzyme that breaks down acetylcholine in the synapse. So neostigmine inhibits the activity of this enzyme. So therefore, acetylcholine hangs around in the synaptic cleft for longer than it normally would. And that gives that acetylcholine a chance to bind to any, acetylcholine receptors that may actually still be present. IV immunoglobulins can also be given, or a monoclonal antibody can be given. Plasmapheresis is a treatment as well. This is where plasma is taken out of the affected person and the autoantibodies are literally stripped, and that plasma then is put back into the person. Manipulation of the thymus as well. And with all of these autoimmune conditions, and we'll learn in the next set of recordings, immunosuppressants are used, and this does include corticosteroids. Final autoimmune condition we're going to look at is systemic lupus erythematosus, abbreviated to SLE, or sometimes more commonly known as lupus. Now, whereas myasthenia gravis was a very specific autoimmune condition, this one causes destruction of multiple tissues. And it's due to multiple antibodies attacking multiple self-antigens and these immune complexes forming that then deposit in tissues to cause inflammation and tissue damage. So it can cause destruction of multiple tissues, often musculoskeletal, damage in the skin, cardiovascular, lungs and kidneys, and also central nervous system tissues. Now, often these autoantibodies target components normally found in cell nuclei, so nuclear materials such as DNA, RNA, and nuclear proteins. So this is the type of autoimmune disease that might occur if there is inflammation or infection or necrosis, because remember, when a cell dies, all those nuclear contents are going to be released into the extracellular fluid, and the immune system will see those for the first time. It won't have any tolerance to the DNA, RNA, or nuclear proteins, and so it will mount an immune response to it and form these sort of big immune complexes then that get deposited elsewhere. Red blood cells and plasma proteins are also often affected. So you can see here, there's lots of, different parts of and regions of the body that are affected. So it's a very variable disease as well. And sort of the severity of the disease depends upon the actual tissues that are getting targeted and destroyed. Now, SLE is more common in women compared to men. And in general, autoimmune conditions tend to be more common in women. That is not to say that this is the case for every autoimmune condition. There is one, for example, called Goodpasture's disease in the lungs that is more common among men. However, it has led to the hypothesis that perhaps, it's the reproductive hormones that are involved in in these disorders affecting women more. Because overall, when you look at the two main times that a woman develops on an autoimmune condition, it is straight after pregnancy and also approaching menopause. And we know that there is a change in the profile of reproductive hormones with those two stages or conditions, and in particular in relation to estrogen. There's also a genetic predisposition, so this is around the HLA type again, plus some environmental triggers. Now, I have included a short list here, but there are lots of other triggers that are suspected too. So exposure to UV light, chemicals that are found in hair dyes, some foods, and also some infectious agents. And this might be, a viral infection, could be one of several, but Epstein-Barr virus has been implicated. And symptoms vary greatly depending upon the tissues that are most affected. Some common SLE symptoms then include arthritis, and this is a bit of a weird arthritis because on radiological examination, there's usually no obvious joint destruction, but certainly people with SLE do report and experience joint pain. The next one is this characteristic butterfly rash. This is a malar rash or a facial rash that sort of resembles a butterfly, and that's why it's called that. It also gives, the E part of the SLE because it's sort of very red and inflamed rash. So this is the erythematosus part of the SLE. Funnily enough, this rash also relates to how you get the lupus part of SLE. Lupus is the Latin word for wolf. And this sort of facial rash here is also kind of resembling the markings of a wolf. Okay, hair loss and sun sensitivity and mucous membrane lesions also occur. There may be effects on the central nervous system, including all of these. And when you think about SLE and you've got these multiple antibodies binding to antigens and you get those large immune complexes accumulating, when this occurs in the glomerulus, it can cause glomerulonephritis, and that will stimulate inflammation and damage and lead to chronic renal failure. Remember, with inflammation as well, the little capillaries of the glomerulus are going to become more leaky, and that's going to allow larger molecules to enter the filtrate. And that's what leads to things like albumin entering the filtrate to cause proteinuria. And also they become leaky, and that leads to edema. And so, if you have the kidney damage and then the fluids, you can't have a process of maintaining fluid balance, then this can also lead to hypertension. If these immune complexes accumulate in the pericardium, that can also cause inflammation and pericarditis. So you have an abnormal volume of fluid in the pericardium that pushes on the heart, and the heart can't fill up properly during relaxation or diastole, and that can lead to heart failure. So SLE then is a chronic and serious autoimmune condition. And if you think about how it can cause, kidney damage, and think about the last topic where we spoke about diabetes also causing kidney damage, kidney failure or chronic kidney disease is becoming much more common. So I'm going to stop here. I just made this little schematic for some of you that might find this easier to follow in terms of the immune disorders. We looked at immune deficiencies. We looked at allergic hypersensitivity reactions and autoimmune conditions. Just bundling together some of the causes of immune deficiencies, some of the causes there of autoimmune conditions, and then just listing, the specific ones that we've looked at.